Oral presentation 11. Utilization and outcome of thrombolytic therapy in acute ischemic stroke in a tertiary care setting. The authors are Dr. Senanayaka HMS, Dr. Lukunarangoda MC, Dr. Veeravansa MRP, Dr. Pilatikia SD, Dr. Sarat Chandra C, Dr. Pushpakumara PHGJ, Dr. Siribardana S. And the presenting author today is Dr. Ratnayaka RMCP.
Good evening. My topic is utilization and outcomes of thrombolytic therapy in acute ischemic stroke in a tertiary care setting. Moving into the introduction. Again, my topic is utilization and outcome of thrombolytic therapy in acute ischemic stroke in a tertiary care setting. Moving first into the introduction, intravenous thrombolytic therapy with tissue plasminogen activator, commonly named Actilase or Antiplase, is a well-known evidence-based and effective treatment for acute ischemic stroke. The benefit of thrombolysis is seen only if it is given within 4.5 hours from the onset of stroke symptoms. So the objectives of my study were, the first objective was to describe the efficacy of delivering thrombolytic therapy. Here I have defined it with timelines, symptom onset to admission time. That is basically the time taken by the patient from the hospital, go to CT time, meaning that OPD admission to take the CT, and onset to needle time and go to needle time. The second objective is to describe the outcome of thrombolytic therapy and here, based on recovery after thrombolysis, I have explained the recovery objectively with National Institute of Health stroke scale, modified Rankin scale, and Barton index score. And the negative outcome, the hemorrhagic number of patients with hemorrhagic transformation, and number of deaths, basically in hospital morbidity and mortality. And this study was carried out in the medical board of Professor Unit Teaching Hospital, Anuradhapura. And their stroke registries maintaining since from 2016, and the data, most of the data were collected prospectively as well as data were recruited retrospectively during the time period of 2016 to March 2016 to June 2020. And the most importantly, this study did not interfere with the standards of patient care, and all patients were managed as per accepted guidelines. And coming to the most important part, the result, the efficacy of delivering thrombolytic therapy. The first timeline I mentioned here is the symptom onset to admission time. Here you see the mean onset to admission time is 190, nearly 2 hours of period. The majority of patients lost 1.5 hours to come to the hospital. So only that 3 patients has come within 1.5 hours time window. And go to CT time. Here the accepted time cutoff depends on the followed guideline. According to the Royal College of Physicians UK guideline, they accept go to CT time less than 60 minutes. But according to the American Heart Association latest update 2018, they accept less than 20 minutes. But in Sri Lanka, crudely we take 40 minutes as the time cutoff. And here in our study, there were 86 patients where the total CT time was less than 40 minutes. But if we go by the American AHA guideline, it was only for 24 patients as a percentage 22%. In total needle time, the standard cutoff is 60 minutes, but here the mean total needle time was 77, which has reached the standard time limit. And most studies recommend that at least 50% of patients should be within the range of less than 60 minutes. But anyway, in our setting, our achievement was only for 33.9% within the less than 60 minutes of total needle time. And mean onset needle time was 193. It was 3 hours, and majority of patients you can see were thrombolized within the time window of 3 to 4.5 hours, as a percentage 65.7. Coming to the outcome of the thrombolytic therapy, here I have categorized the severity of the stroke as 1 to 4 category, mild stroke, and 5 to 15 moderate, and 6 to 20 moderate to severe, and 21 to 42 the severe disease. And I have compared it with the NIH score on admission and NIH score following 24 hours of thrombolytic therapy. And here you see there were none in the zero category. Of course, zero if the score is zero, it is not an indication for the thrombolysis. But following the 24 hours of thrombolytic therapy, 4 has come to the zero category. And 1 to 4 category, initially on admission, there were 17 patients, and following 24 hours, there were 40 patients. So you can see here clearly, following thrombolytic therapy, the patient has come from the more severe categories to less severe category. That shows the improvement following thrombolytic therapy. And as a mean, the mean admission NIH score was 11.1, and mean NIH score after 24 hours of the thrombolytic therapy is 7.8. So here, if you consider the mean difference, it is about 3.3. And most studies recommend that more than 4 improvement of the NIHS score as a significant improvement. So in our setting, there were 39 patients. As a percentage, it was 36.6, had more than 4 improvement of the NIHS score following the 24 hours of thrombolysis. On discharge, the modified Rankine scale was less than 2, and modified Barthel index was more than 15. That means the patients are nearly independent or independent. Crudely, MRS less than 2, there were 58%, and Barthel index more than 15, 47. So half of the patients were independent or nearly independent on discharge, and Barthel index was almost 20. That means the patients were fully independent in 22.9%. And as the negative outcome, there were 10 patients died before the discharge. And in most researchers, they mentioned the in-hospital mortality rate in between 8 to 11. Again, we are in between range the in-hospital mortality in our study. And 13 of patients reported hemorrhagic transformation following the thrombolytic therapy, and among 7 have died with symptomatic hemorrhage. And coming to the conclusion, the pre-hospital delay time was more than 1.5 hours in the majority, and the majority received thrombolytic therapy within 3 to 4.5 hours of time window. And prolonged dose-to-needle time was noted due to in-hospital delays, and prolonged onset-to-needle time was noted due to pre-hospital and in-hospital delays. Half of the patients were independent, as by score I mentioned, on discharge, and the outcome of thrombolytic therapy could be further improved by identifying and minimizing these delays. So these are the references I have used in my study, and thank you.
Okay, now it's time for the questions by the judges.
You said that your study, you have this stroke registry that has been made.
Yeah.
And then you said that this is a prospective study.
Yeah.
If that is the case, what do you think that what would have been the better way to find out the delay in coming to hospital? What sample would have been better for you to decide on delay in coming to hospital?
Actually, the registry is maintained. This sample include only the acute ischemic stroke who has undergone thrombolytic therapy. So, in case most of the data were collected.
So you have data. You have data at home, but it's not there. You have the registry. To find out the delay.
Yeah.
You have to include all stroke, no? You have sample at home, no?
Yeah.
Registry has the data of all the strokes.
Yeah.
So this does not give you the.
No, this is only the acute ischemic stroke. Yeah. The delay more
thrombolized.
For the acute.
This is only few thrombolized.
Few thrombolized. Yeah. This is the sample only the thrombolized patient.
And then you said that your 10-11% level of hemorrhages.
Yeah.
And then you said that 10 died. Not out of the one's hemorrhages.
Yeah.
But then another 10% or 10 died.
Yeah. No. Altogether, only 10 patients died.
Yes.
Right?
Yes.
Here, and 13 reported hemorrhagic transformation.
Yes, out
From
of them,
that 10, 7 that included into that 10, that 7 died due to symptomatic hemorrhage. The other 2 were cerebral edema and 1 was other cause, maybe aspiration pneumonia and so on. Anyway, in the sample, only 10 has died.
so
Cause of
thrombolized, non-thrombolized, all only 10 died.
Yeah.
No, this is only thrombolized.
Yeah, only
Only thrombolized.
Yeah.
And all 10 are hemorrhage. All 10 are hemorrhage.
No.
Only 7
7
are.
hemorrhages.
So the cause of death might be different.
13 hemorrhagic
Yeah,
transformation.
13 transformation are there, but they were managed conservatively.
Right.
In hospital, there were no in hospital death. Okay.
So the
They
course,
might,
7
yeah, they might die after the discharge,
who
but
died
in
of
hospital,
hemorrhage.
sorry.
The 7 who died of the hemorrhage.
Yeah.
What was their initial stroke severity? Were they very severe deficits? Did you look at?
Yeah.
To
You mean
stop
like
down?
96 score?
Did you look at why
they develop hemorrhage?
any?
Yeah.
Are they diabetics? Are they with very high blood pressure on admission and with the U control and gave thrombolytic? Why did they develop hemorrhage?
Yeah. Actually, yeah, I didn't look into the etiology of that, but the sequelae was the hemorrhage. So to decide on that, I have to trace the.
When you thrombolyze,
Yeah.
do you discuss all, say, do you have follow-up meetings for these patients?
Yeah.
And then do you try to shorten the time windows?
Yeah, actually, the follow we are following up patients in 3 months, 6 months, and
No, I'm not asking that.
Yeah.
I'm asking the thrombolytic program. Your
Okay.
the members of the thrombolytic program.
Okay.
The OPD doctor, radiographer,
Yeah.
all these. Do you meet and discuss each and every case after thrombolysis?
No. Actually, the thrombolysis program was started in teaching hospital Anuradhapura since from 2016. Actually, it is developed gradually and up to not yet come up to that level. And it is only the professorial unit, the medical board professorial unit. So that team, these patients are including only the thrombolyzed by that team. In that
there are other patients.
Other patients in the there are 4 medical units, and there are the patients thrombolyzed in that unit as well, madam. Right. Thank you very much. Thank you.